This program is brought to you by Emory University.
Okay, good morning, everyone. It's a pleasure today to have Dr. Chuck Lingam with us. And he is actually from the University of Missouri in Columbia. And he's based predominantly at the VA there for his clinical work. He has done a lot of work on cardiovascular rehabilitation there, as have some of the other members of our group here as well. And today he's going to be telling us about his HFpEF, reversible cardiomyopathy, and evolving concepts in this field. Dr. Chuck Lingam.
Thanks so much, Gautam. It's a pleasure to be at Emory. Let me go ahead with the slides. I'm happy if people would like to unmute yourself and ask questions as we go along, but I'll try to keep it to about 45 minutes so that we'll have some time for questions and discussions. We'll get started. Is heart failure a reversible cardiomyopathy? My disclosures are highlifejourney.org, which is our nonprofit where we want people to get online to see what they can do for their own health. Seeking Hunger is a small book, and I'm an advisor for Blue Earth Ventures and Cardiac Wellness Institute. Today's learning objectives are the diagnostic challenges we face with HFpEF, the contribution of obesity to heart failure, weight loss and cardiac hemodynamics, and is HFpEF truly reversible? We'll start with the diagnostic challenges. We recognize there are several million adults in the US who are dealing with heart failure, and the cost in 2020 is over $43 billion. It's not a small amount. And we know that heart disease accounts for at least 1 in 3 deaths in the United States. And now, unfortunately, even in the developing world, heart disease has become the #1 killer, both for men and for women. When we say heart failure, there are several other things that are present in majority of the heart failure patients, like mobility disorders, pain, carrying out routine activities, and mental health issues like anxiety and depression are present in half to 2/3 of heart failure patients. Once the diagnosis of heart failure is made, it has a up and down course, and prognosis is poor until we optimize medical therapy, which is ACE inhibitors, beta blockers, and spironolactone, and all the other agents which are proven to improve survival, but they all are effective in heart failure with reduced ejection fraction. And this we know since 2013 guidelines that if we can recognize stage B or even at-risk people at stage A, we can prevent the development of the first episode of clinical decompensation, volume overload, pulmonary edema, either for HFpEF or HFrEF, and thereby improve the natural history. Now, in the last decade, we have seen a significant increase in HFpEF to the point that it is now already the majority compared to heart failure with reduced ejection fraction. So this is the first time in our human history that this has become the reality in the last few years. So heart failure annual hospitalization itself is over 1 million just in the US, as well as in the Europe, again another 1 million. Majority present with signs and symptoms of fluid accumulation. Readmission rate, we know, at 30 days is over 20%, within 3 months, 1/3. And by 6 months, half the patients with heart failure are back in the hospital. Mortality is 4%, which is not that far behind acute ST elevation myocardial infarction. Once a patient has acute heart failure, within a few months, it is 10%. A year, it is 25%. By 5 years, most heart failure patients are not able to survive. This is worse than most cancers. When we look at the difference between HFpEF and HFrEF, unfortunately, prognosis is not that different. At 1 year, 2, 3 years, and 5 years, they track very closely. And this is the biggest challenge, that we have some good natural history modifiers for HFrEF. For HFpEF, we don't have much at this point. We'll discuss a quick case to see where the challenge may be. This is a 64-year-old I saw very recently in clinic. Oh, not in clinic, in the echo lab, we got to see this echocardiogram. This is a patient who presented with leg edema, dyspnea, palpitation, fatigue of 2 months duration. Long ago, she underwent vertical banding gastroplasty. 15 years ago, she underwent Roux-en-Y gastric bypass. However, her BMI continues to stay over 40, and this is her weight curve from 2008, 2016. You can see all along it has, here it came down with the second gastric weight reduction surgery, but then she has regained all that weight. And these are her comorbidities, which is what we often see in many of our heart failure patients. This is a primary care physician when dealing with these symptoms. Without going for a chest X-ray, an echocardiogram is ordered to rule out heart failure. We know that heart failure diagnosis for several decades has remained clinical. And these are the criteria. If patients make 2 criteria, or if they make only 1, we want to make at least a couple of minor criteria and weight loss to make the clinical diagnosis. Here, BNP still does not feature, echocardiogram does not feature, but anytime there is a question of heart failure, we know that most providers resort to an echocardiogram these days. So the echocardiogram was performed, and this is the report. There is more than normal, but very little increase in pulmonary pressures. That does not meet criteria. E by E prime is within normal limits. LV function is normal, EF is 65%. It is reported officially 55 with moderate left atrial dilatation, and by Doppler diastolic function is normal. So if this report goes out to the primary care doctors, they may not recognize there is anything heart related going on in this patient who has clinically leg edema and all the other clinical features of heart failure. In this report, we included 2 sentences. Cardiac output is elevated by Doppler. Patient needs further cardiac evaluation to evaluate specifically for obesity-related HFpEF. Now we know these guidelines to go over how to detect diastolic dysfunction, especially when the EF is normal. It becomes a little more challenging, but we know the Doppler parameters. I'm not going to go into the details. These are the more recent European guidelines where if the suspicion is for HFpEF based on clinical signs and symptoms, and echocardiography may or may not reveal the needed features, exercise is useful, and then exercise diastology may be useful, invasive hemodynamics, and then to confirm the etiology, further testing, cardiac MRI, PET, CT, genetic testing, a lot of things are on the table. This is, I think, a very simple, direct, practical scoring system that was published recently using a very memorable mnemonic, HFpEF itself, using excess weight BMI more than 30, which has the highest score, second only to atrial fibrillation. High blood pressure and age over 60 all score only at 1, and PA pressure more than 35, and diastolic function. So this definitely requires echocardiogram to get the full score, and the probability of HFpEF goes up to 90-95% based on more than 7 of these criteria being fulfilled. This came out from Mayo Clinic based on their earlier study looking at pathophysiology of high output heart failure. We know lung disease and AV fistula can cause it, but in this day and age, the number 1 reason for high output heart failure ends up being just obesity. In their cohort, what they found is BMI need not be extremely high, just a BMI of 40, which we see quite often in our day-to-day practice, and age of about 60 was sufficient to cause high output heart failure in their series comparable clinical presentation to people with AV fistula and myelodysplasia. This is the challenge that we are now facing. Our criteria were developed in the 70s and 80s to diagnose clinical heart failure, and we are trying to evolve better tools to diagnose HFpEF. But obesity is actually increasing at an even faster clip. Compared to 1990, when we fast forward to 2030, the prevalence of obesity in the community has gone up from less than 10% to nearly 50%. And we look at the specific entity of severe obesity, even that is reaching close to 36%. So this is where we are dealing with a high population prevalence of obesity that is contributing to HFpEF. And the challenge has been most of the big trials over the last 2 decades have excluded obese patients to evaluate various agents to see outcome differences. If you look at the most recent publication, Emperor Preserved in New England Journal a few months ago, BMI up to 45 was included, which is a huge increase compared to prior studies. But still, if BMI was 46, that itself would disqualify them from participation in these outcome trials. And this Emperor Preserved, looking at empagliflozin, showed there is a subtle improvement in rehospitalization rate. We could not show significant improvement in mortality. So this is where we are. And this study done by Dr. Alpert from University of Missouri in the 1970s clearly showed that the duration of obesity played a significant role in increasing the probability of obesity cardiomyopathy. He is the first person to characterize this in the 90s. And he said at 15 years, the chances of obesity causing heart failure may be at about 20%. And if the obesity persisted for over 25 years, the probability dramatically goes up to about 95%. So how long a person is obese makes a huge difference. And now we are looking at the back end of this, you could say. If people through gastric bypass are able to lose a substantial amount of weight, which happens to be about 43 kilograms on average, and we have the luxury of having invasive hemodynamic monitoring in patients with obesity and symptoms of reduced functional capacity, but they did not have clinical heart failure. So all this data was compiled again by the Mayo group. And what we are seeing is 20 to 40 to 50% reduction in several parameters, favoring improved hemodynamics. Right atrial pressure gets better, LV, EDP, and wedge pressure gets better, pulmonary artery pressures get better, and oxygenation improves in people who lose significant weight, even though they may not yet clinically have heart failure. So this is very useful information for us, which suggests that we need to go for a significant amount of weight reduction when we are dealing with heart failure symptoms. And then they looked at this specific obesity phenotype, which is a subgroup of HFpEF patients. If you look at HFpEF, in the Mayo series, the age was 70. And in the obese subset, the age was younger, 5 to 10 years younger. And BMI obviously was much more for this group. And what they were able to show is from BMI of 26 in the HFpEF group, the BMI was 40 in the HFpEF with obesity group. And if you look at the BMI increasing, they were able to show wedge pressure goes up significantly with increasing body weight in their specific group. So this was the first study specifically looking within the HFpEF population to show that obesity may cause symptoms and presentation even 5 to 10 years earlier because of the excess weight. So this is a paper that we just published in Frontiers, and this is just a hypothesis. But what we were able to show is this group here is the mean age and BMI of Emperor Preserved in last year's publication. So the average BMI was just at about 30 and the average age was around 72 years. And then this group is the Mayo's obesity HFpEF population, which has an average BMI of about 40 and age is about 65. And then we also took several studies that had obesity cardiomyopathy that underwent gastric weight reduction surgeries. And much of this data is collected over the last 30 years. But there age range was in the 30s to 40s, and their BMI had a much wider age BMI range of about 45 to 70, 75. So when we draw this line, and that line happens to be a very simple math, BMI plus age, that's it. And if that is equal to 100, you get this line. So we find that line crosses all these groups. And what we suggest is many people between the younger preclinical HFpEF, which would be stage A and stage B, versus the actual HFpEF stage C clinical patients, there is a lot of people who may not be recognized as heart failure, but who have much of the challenges that we face with heart failure and preserved ejection fraction. So obesity, we are saying, is directly contributing. So this parameter can be used by primary care providers, nurses, even patients can raise their concern for HFpEF based on their BMI. Symptoms we know is multifactorial. We attribute it to so many other things, including deconditioning and lung disease. Obesity itself can cause HFpEF without requiring hypertension, atrial fibrillation, other comorbidities. The exam is limited for JVD, and edema itself may be non-specific in many of these patients. We know that diastolic dysfunction by even trial criteria is not fulfilled in many HFpEF patients. A third of them don't fulfill many of these criteria. Even catheterization is a challenge because it becomes invasive, and a lot of our patients are on diuretics, and just to get through the catheterization, we might not be able to do it without diuretics, and EDP we get there may not be truly reflective of that challenge. What we want to ask people to look at is the entity called obesity HFpEF if patient improves with significant weight reduction, and we set an arbitrary number of 20% weight reduction. So that may seem too ambitious or not practical. With gastric bypass, we know we can get there. Let's look at a few cases. This is a patient we saw in our cardiology clinic. But when I went through the prior records of this patient, going back to 2006, she had already presented with dyspnea. And by 2014, she presented with angina. By 17, she had actual pulmonary edema, and 2020 and STEMI. She had 2 catheterizations in 2014 and 2020. EDP was 26 at this point, only 13, likely because of diuretics here. Her BNP trend is not that dramatic. Her PA pressures are somewhat elevated. E by E prime showed some elevation, but even that is not consistent. Left atrial dilatation, again, we know between different sonographers, you may see significant variability in this also. So this is her story. Now, when we fast forward to 22, her age is increased to 75. But now she says, doctor, after 15 years of dealing with all these heart problems, I'm now finally feeling like I was 50 years younger. And BMI has dropped from 35 all the way to 26. At 74, it's not often that people undergo gastric bypass surgery. Her BMI years criteria is still at over 100. So it hasn't dropped when we add her BMI plus her age. This is what has happened to her. This we have published recently, her story, where this is the y-axis is her weight of 104 kilograms in 2020. Within 8 months, it dropped close to 35%, and it continues to stay down after 1 to 2 years. So this is, we feel, the key change that has happened in her life. And if you look at 2013 look ahead study that used several centers and NIH funding to evaluate cardiovascular risk reduction in people who yet did not have heart failure but were at risk because of their diabetes and metabolic problems. What we ended up finding is we achieved at the end of the day 6% weight reduction, and between control and the intervention group there was not that much of a clinical improvement. The study was a negative study for lifestyle in preventing heart-related comorbidities. This was representative of the best current lifestyle clinical results. in look ahead, we failed to reverse diabetes or obesity. And because we did not reverse those, we did not reverse cardiovascular risk either. We do know from gastric bypass literature, this is from Sweden, where we have about 20 years follow-up, that there is a durable weight reduction. Excess weight takes away 7 years of life on average, and having gastric bypass at an early enough stage in life, usually in the 30s or 40s, gives back half of that life. And this is because BMI reduction of about 5 kilogram per meter squared, the BMI 5 points reduction persists over 5, 10, 15 years. So that is what is needed, a significant weight reduction to reduce the long-term risk. So this is our cardiometabolic group clinic. Thanks to our Truman VA Hospital in Columbia, we've been doing this now for last 5 to 6 years. As a Friday known way of giving back to our community, we started this. Then it became a formal group clinic for patients, their families, providers, doctors. Anybody interested could join us for 8 Friday noon sessions, where we talk for about 30 minutes about various things about diet and exercise and mindfulness and other things. For 15 minutes, we do question answers, and last 15 minutes, we have a chance to practice some mindfulness method. So at the end of 8 weeks, most patients have learned about 20, 25 different tools they can continue to explore throughout their life. So this is thanks to the Whole Health Initiative at the VA. Now in the COVID world, the whole program is on Zoom, and we have close to 150 people signed up from all over the world. And now the series is going on. So once I'm done here, I'll go to understanding flow, yoga, Uvagai, which is Siddha consciousness, and meaning in life. So these are the concepts we'll be working on today. So this is ongoing, and we feel it has shown the real role the mind plays in cardiac rehab, where we started, but now in HFpEF, and anybody at risk for heart disease can bring to bear their own subconscious potential to improve their health through lifestyle transformation. So look ahead gave us 6% weight loss, which was not good enough. Gastric bypass done very early in life gives us 16 to 18% weight reduction. Through this heartful living online, we call it high life, we get 20, 25, 30, 35% weight reduction when people stick with us for 1 to 2 to 3 years. So the benefit from cardiology and our evidence-based medicine is an acute myocardial infarction, acute decompensated heart failure to improve lifespan. But when we bring these ancient alternative medical system from Tamil Nadu, which is Siddha medicine, it integrates and gives health span. It improves mind-body coordination through sports and martial arts and dance. So creativity is enhanced. And through meditation, we can work towards higher consciousness. And this also is the source for yoga, and we can improve health span and creativity through that. But just through the self-inquiry or meditative aspect of Siddha, we are able to check off all these boxes. So this 4 lines summarizes what 5,000 years Siddha tradition says. Andam surungil adarkor arivillai, pindam surungil pranam nilaipadum, undi surungil ubayam palapala, kandam karutta kabali mame. What this beautifully connects is higher consciousness with our diet and with our health. So if we turn our attention inwards, our mind becomes stronger. When we reduce our BMI to 25 to ideal weight, we live for over 100 years. When we reduce our food intake even afterwards, say if we move towards a BMI of say 22, then the benefits are too many. It says it itself detoxifies not only the body and the mind and allows us to work towards higher consciousness. So this is the premise on which we worked for the last several years, but I did not think so many patients will be able to take up at the age of 65 these deep mindfulness practices. But what they did within 1 to 2 years is reduce their weight from an average of 125 down to about 100 kilograms. BMI dropped about 5 to 6 points, and so many clinical parameters improved, including LA size and diastolic parameters, PA pressures, and LV dimensions improved. So this is a small series of only 10 patients, but I think it gives us a window into this question: how much of the cardiometabolic stress the body undergoes and how much of it can be reversed even up to the age of 65 through lifestyle. So these are the mechanisms which we reported, but much of this is still hypothetical. But hunger gratitude experience. So this is the Siddha fasting, and this does not require a specific number of hours of fasting every day, this many calories, this many footsteps on your Fitbit. It is pretty intuitive, and we allow people to find things that work for them in their own life circumstances. But the mind aspect is so important. They have to be able to feel the gratitude and continue to smile 20 times every hour is what we request. I mean, we are not counting the times that they are smiling, but this program primarily works through building optimism. We know they go into ketosis naturally by metabolic switching, because at least once a week they are going to 18 to 24 hours of zero food intake, just water. And we know their blood pressure comes down because their medication requirement comes down dramatically. So with weight loss, their diabetes gets better, their heart failure dramatically improved, and quality of life and rehospitalization shows significant improvement. Those 10 patients, we have their details at the end of our session. If we have, we can go through their cases individually, but none of them were rehospitalized except one patient who died. We don't know the exact reason, but the other 9 people, for 2 years, 3 years follow-up, they have not needed even a single rehospitalization for heart failure. So that is in the outpatient setting. What about HFpEF acute decompensated heart failure who is in the hospital? This is a 65-year-old who was in the hospital for 3 weeks, and because of acute on chronic kidney failure and worsening ejection fraction to about 25%, all the heart problems that we know of, AFib and mitral regurg being severe, been on Coumadin for a decade, and morbid obesity, pulmonary hypertension, PA pressure 55. At the outside hospital, after 3 weeks, they still wanted to do the coronary angiogram, and because of the risk of renal failure and dialysis, which the patient's family had undergone and had a very poor outcome, patient said, I will take just conservative care, even if it means the end of my life, I'm okay with that. He came to us for a second opinion, and at that point, we have fast forward only 4 months. By March of 2021, patients' diuretic requirement had decreased by 65%. CHF-EF was still down, but improved to 40%. Mitral regurgitation had become only mild already. And a patient who has been NYHA class 4 requiring a wheelchair to get around for the last several years, within 4 months is now taking 4,000 steps on his Fitbit, does 4 hours of yard work, and is doing upper extremity exercises as well, and is completely independent after about 5 years of being dependent on so much support. So how did this much happen within 4 months for somebody who was nearly terminal? Did we do a balloon bypass, mitral clip? All that we did was our Siddha fasting for 20 hours on 2 days out of 7 days in a week. And he cut back on his meat and empty sugar content in his food. He learned the value of every day being hungry for a little bit. He discontinued daily diuretics and within 3 months was able to ambulate, and he reported feeling 15 years younger. He is not yet feeling 50 years younger, but this is a huge gain for him. And this is his weight curve. From 157 kilograms, he's lost about 14 kilograms. And this is reported separately because this is an acute heart failure. This is not chronic ambulatory heart failure. So this is a patient needing hospitalization who's improving in several parameters. His kidney function dramatically improving from a creatinine. When we saw him, he was at about closer to 2.5 creatinine that stabilized. And then his BNP over the last several months has only improved. And I showed you 3-month outcome. Now I'm showing you out to 2022. His weight is only continuing to stabilize and continue to come down. He has now altogether lost 15% of his weight and reporting feeling even better. So there are so many hundreds of patients now at this point where their weight reduction, if it is over 20%, their chronic heart failure is better. And if their acute improvement, if they have ability to take up these type of meditative calorie restriction in the hospitalized setting that reduces their cardiorenal syndrome risk and hospitalization length. So how does this weight loss and fasting work on cardiac hemodynamics? We have to go back in a patient's lifetime to teenage. If we go to a 15-year-old and see what is their biggest factors associated with high blood pressure in adolescence, there is a 10-fold increase if there is obesity. So there is no question if or why there is a role for obesity in high blood pressure and heart failure. So this is alone sufficient proof for the role of excess weight in cardiac risk throughout life. We know that BMI itself is not the best indicator because athletic people who build a lot of muscle is heavier than fat, so BMI may be over 30. But if we look at our most recent updated cardiac guidelines for heart failure, the entire update mentions obesity only once and says there is only weak evidence for any intervention on weight itself. So if the BMI, and it doesn't even feature in the comorbidities survey, all the comorbidities for heart failure, we don't even see obesity being mentioned. And the Europeans are also perplexed by this challenge. Obesity may contribute, but weight loss as an intervention has not shown to improve outcomes. And if you look at people with maybe BMI more than 35, weight loss surgery may be beneficial. Again, our heart failure patients are a lot of times too many comorbidities and not suitable for gastric bypass surgery. And this is another big challenge. This concern that obesity and BMI is more than 30 paradoxically improves heart failure survival. So this is the obesity paradox. I'm not going to spend too much time on this, but this has left not only cardiologists and primary care providers, but this information has reached the public to the point that they feel their weight may in some way protect them from heart failure. But this is what we see. When the BMI goes below 20, mortality goes up dramatically. That is because of cardiac cachexia. We know that's not a good thing. But when we look at BMI going about 25, 30, 40, 45, that does not seem to me a dramatic increase in mortality. So the sweet spot, they say, maybe around 30, 35, which I feel has been misguiding for the real narrative. So obesity paradox is because of cardiac cachexia, and obesity makes people present much sooner, so they get medical attention faster, and we don't have good data on sufficient amount of weight reduction in heart failure patients to show the real benefit of weight reduction. And people with say BMI of 25, they have heart failure, they have that despite having less problems. So this paradox, which is applicable for smoking and so many other things, just means that the obesity has contributed to it, and we need to clarify that message. So if you look at actual natural history, long-term studies that go more than 3 to 5 years, there is no question about the role of obesity. Excess weight dramatically increases the risk for heart failure. Every 1 BMI increases the risk for new heart failure by about 6%. So that there is no two ways about thinking on that, and that is 20-year-old data. And then if you look at diabetes and as a surrogate, even obesity, that has dramatically increased in the last 2 to 3 decades, doubled from say 20-25% of the study population to already at about 50%. So that is where the obesity and cardiac hemodynamics are involved. So specifically, how much of this can we reverse with the HFpEF patients? We know that BMI has been dramatically increasing over the last few decades across the population. And compared to the Western world, US is head and shoulders above every other country in the world, to the point that even children have 13 to 20% obesity. Adults are nearing 50% obesity in this country. And if you look at this graph of most obese states, that is where we see a lot of cardiac death also. And this is a few month-old publication in JACC saying the only medicine that we thought might improve HFpEF symptoms is actually worsening HFpEF symptoms. So when we stop a beta blocker, exercise time actually improves. So this may be the next trend that we will start to embrace discontinuing medicines. And this is the real challenge. HFpEF is not progressing one step at a time. HFpEF is all of this put together at the same time. And when this works for 10, 20 years, it directly leads to HFpEF. So we had recognized this in 2008, and we thought exercise is the way to figure this out. So we started home-based upper extremity exercise programs, and people felt really good about it. Exercise time improved dramatically with our disabled veterans, but still we were not able to make enough improvement because calorie restriction plays a dramatic role in improving resilience, which drops off over age across the animal kingdom. So this cutoff point may be 40 years. So before 40, if we start lifestyle change, we can even prevent heart failure. And this graph that we published, I want to bring it back to show you that if BMI and age, say for a 50-year-old, his BMI is 50 and he has heart failure and we diagnose it. And if he drops his BMI to 40, he can go on for another so many more years, another 10 years so well. And if he continues to drop the weight, he can stay under this radar throughout his life. So what we are requesting is for people at every point, have this wake-up call, see where you are. You don't have to reach 100. A lot of times with other comorbidities like hypertension and lung disease and smoking, BMI plus age of even 80 may be good enough to cause HFpEF. But whenever that diagnosis is made, if we can start losing weight and say 20% weight loss and stay in that range for a long time, we can reduce that risk throughout life for symptoms and problems. So we use primarily, as far as diet, calorie restriction, plant-based anti-inflammatory foods, and our Siddha hunger gratitude, which means 14 hours every night and once a week, if possible, up to 24 hours of zero food intake, just water. So I'll leave you with this last case. 15 hospitalizations and 3 cardiologists take care of this patient in different centers because of excess weight. A 70-year-old with a BMI, you see the weight here, and learned our methods while in the hospital. And I've not interacted after that. Just once I spent 1 hour with her. And for the last 1 year, she has kept out of the hospital. This also we published, saying it's not the percentage weight reduction, but recognition that food is directly contributing to HFpEF, that she is able to recognize the value of being hungry every day for a little bit more. Her food intake, I would say, has come down by about 50% of her baseline. So this is the mechanisms in which, in the hospital setting, gratitude may give empowerment and sympathetic stress reduction. Fasting causes ketosis, and we know natural ketosis in the hospital has a chance of reducing vascular resistance. Cardiac output can improve directly, and peripheral vascular pulmonary vascular resistance goes down. Fasting itself reduces the coronary steel and itself has a direct diuretic effect. So we may be able to reduce Lasix requirement and cardiorenal syndrome. And when the EF and cardiac output goes up, we are directly impacting acute heart failure. So again, this is not for everybody, but we are finding surprisingly that more and more people want to embrace these type of methods in the hospital because it is empowering and they feel they are participating in their road to recovery. So I want to thank so many of my collaborators in cardiology, in Siddha from India, in exercise physiology, behavioral psychology, psychiatry, and our residents and machine learning team. And especially I want to thank the first 100 patients who said, Anand, I will trust you. I will cut down on my food intake because you say it may help me. Now there is no question of potential reversal. We have already shown how much benefit there is, and we are publishing as we go along. And what we are publishing is increasing our compliance from, say, 5 to 10%. Already we are at 60 to 75% compliance in the hospital and outpatient setting for these holistic methods, especially when the BMI is over 30. In our not only HFpEF, it works for HFrEF also, but HFpEF is directly due to obesity in a lot of our patients. And they've shown us that what I'm noticing is heart patients and their families are actually changing my understanding of cardiology. So this is a small book we wrote to inspire more patients to not do this many calories or that many hours of fasting, but to directly take up being hungry as a natural way of being healthy. So this they have to recognize is throughout life. that their commitment to a few hours of being hungry is so simple, so intuitive, and it only requires some water. So this half full, half empty, all of this thing that we work with our logical mind is only a construct. Once we do self-inquiry and recognize the value of deep consciousness, we will find that our gratitude is actually so full that our life is overflowing with zest. So we do this for ACC, for physician burnout, and we do this as a Missouri wellness program also. Very similar concepts to help doctors cope with their own challenges throughout life. And all of this we try and save in highlifejourney.org. So anybody is welcome to find most of these material. At least since the pandemic, we were able to save much of this material in here. And I want to thank everybody for this opportunity to come to Emory and present our research. And my information is here. And I'm so happy to see what we can do together to improve our understanding of cardiometabolic problems, how we can take up these cardiac resilience initiatives and inspire more patients, their children, as well as their grandchildren, so that we can prevent heart failure altogether. And we are working with NIH now. So if providers and researchers in Emory are interested in working with us, we are so happy to collaborate and see what we can do together in this HFpEF space using our simple yet profound mind-body methods. Thanks so much.
Thank you so much, Dr. Chuck Lingam. That was absolutely fantastic. And I really enjoyed the comprehensive sort of review of obesity and relationships with HFpEF. I'll start off with a question, while I know we'll have lots of questions, so people can type in their chat or unmute. I'll start off with a question. When I saw the criteria, a lot of these patients don't meet the criteria for diastolic dysfunction, two-thirds you mentioned. Do you think that's because, do we need to change the criteria of what we call diastolic dysfunction? Wanted to get your thoughts on that.
2/3 of our HFpEF population make the criteria, which means about a third don't make the criteria.
I see.
We've been tinkering with these criteria for the last 20 years, ever since we came up with HFpEF as an entity. And I think we have excellent criteria. And if you ask me why many people don't meet the criteria, I'm going to give you a provocative thought. Maybe they don't have heart failure. Maybe they just have obesity. That is what patients are now telling me. So once we fix that obesity, their heart will be just as good as some other 40-year-old, 50-year-old, or 60-year-old of that same age group without any problems. So that is why I showed a little bit of evidence from the same Mayo group that looks at high output heart failure. So when the cardiac output is great, more than normal, and the EF is fine, and the diastolic parameters are also fine, maybe their heart is truly healthy. They just need to recognize that they need to lose the weight. If gastric bypass is needed, that is okay, but that leaves people with a lot of psychological trauma, and sometimes they don't even lose much weight, like the case I showed you. After 2 surgeries over 30 years, BMI is over 40. So we have so many patients after gastric bypass who come to us and who are able to learn these type of things. For this Siddha hunger, gratitude, fasting method that we use as a meditative concept, I need a patient, but I also need a patient's support. It can be a grandchild who's only 15 years old. It can be a spouse, but we need some support at their home. But once they have that social support, then they're able to embrace this, because this needs a lifetime commitment.
Yes, social support, and also sort of, I really like the mind body, because, one of the things is that if you're stressed, because I think about women particularly, there's a lot of emotional eating pattern. So,
Definitely.
that controlling, however method, whatever method it is, to kind of help control the mind would definitely help. Did Dr. Smith have a question?
Yeah, just a question about what we do in the Echo Lab. I know Barry Borlaug at Mayo has really shown the obese phenotype with HFpEF. One of the hallmarks is that if you exercise them in the cath lab and monitor hemodynamics at the wedge pressure will acutely go up much more than with volume loading. And are there ways that we should be trying to elicit these types of responses, maybe in the echo lab? Are there things that we should be doing?
In academic centers, what you're asking is excellent. And in Mayo and Emory and where I am at the University of Missouri, we may still be able to do a lot of these things. Even if we can put somebody on the treadmill and do exercise diastology, we can see significant increase in E by E prime, PA pressures. But then a lot of our obese people are not comfortable on the treadmill. Sometimes they exceed the safety limit of the treadmill to even get on it. So in the cath lab, if we can do some exercise and give them a fluid challenge, or even otherwise just by exercise, we may be able to show increase. But the real world, majority of people are not able to access advanced centers. They get care in the community, and many don't even go to a cardiologist. They are cared for 5, 10, 20 years of their life by primary care providers and treated for pneumonia or treated for COVID or so many other things without even recognizing that they have a significant component of HFpEF. So that's why we came up with this BMI plus age. But there are going to be several patients who are borderline and who have so many other issues where we want to characterize this further. My simple request is everybody recognize that weight is directly adding load to the heart. And like detraining athletes, we need to work towards losing weight, and that's going to help everybody across the board. And we will see how much of their clinical improvement occurs. That itself may be sufficient, but otherwise definitely we may have to take them to the cath lab or to the treadmill exercise based testing to elicit occult diastolic dysfunction, which may be occult in about 10%. 80 to 90% we may catch with the clinical criteria and by baseline echo itself.
And just a follow-up question for patients who are successful in losing weight. Often these patients may start out on quite a number of medications. What sort of safety features do you put in place as they lose weight? You know, particularly if someone might have been on spironolactone and a loop diuretic, if they were to get volume depleted, they might develop hyperkalemia. How do you coach your patients who aren't on medicines?
Until 2015, I came to work at 7 o'clock. Since 2018, I'm coming in every day at 3 or 4 in the morning because patients are teaching me so much of cardiology. What I mean is, as a cardiologist, when a heart failure or MI happens, on top of 14 other medicines, I'm adding 3 or 4 medicines for the heart. Now, when people learn this mindfulness and intermittent fasting or Siddha fasting, however they take it up, out of 20 medicines, 17, 18 medicines are coming off. So that is why I want to see how I can understand this better to inspire more patients to do this. So that includes a lot of heart medicines, depression, arthritis medicines, diabetes medicines. When they lose over 15% weight, life transforms. And how we manage this is I ask them to follow more frequently with their endocrinology, primary doctors, and their psychiatrists, and with their cardiologists. Because this Heartful Living High Life, what we do for 8 weeks, I don't directly involve in their patient care. So they may come back to my clinic, but we need to cut back on medicine. So every day or at least a few times a week, they are asked to check blood pressures. Diuretic requirement goes down first. So Lasix can come off in many patients, and then spironolactone. And then depending on EF is okay in most of our HFpEF patients. So which medicine they stop is only an academic question. So by the end of 15 to 20% weight loss, most of these medicines are off. And this may take only a few months for some people. For some people, it takes up to a year.
Going along with that, so if a patient is a diabetic, how do you, when you're telling them to restrict calories for a certain number of hours, how do you, because, don't you worry about hypoglycemia or, just because they're on meds, I usually tend to think, okay, you're taking a lot of medications, you need to make sure and eat on time.
Yes, this is a real world challenge. And what we find is endocrinologists and even nutrition, dietetics people, their comfort is with ensuring adequate intake so that the sugar levels can be maintained. My interest is not to maintain sugar levels. My interest is in actually reversing heart failure. In that process, we are reversing diabetes also. But for this, if they are not yet on insulin, this process is 10 times easier. If people are on insulin for the last 10 years, still we have so many people who have come off after they lose 20% weight. But this has to be done very carefully. They have to know what they are doing. When they cut food intake, insulin, long-acting insulin requirement goes down at least by 50%, and sliding scale, short-acting insulin goes down to 0 on days that they are actually fasting. But we don't encourage fasting for insulin-requiring diabetics, cirrhotic patients, pregnant people, or eating disorders. We don't recommend fasting directly. We ask them to learn how to smile first 20 times. That's the hardest thing, how to be grateful for something specific in their life and every day. And after a few weeks of learning that subconscious strength, then little bit of calorie restriction is where we start for in brittle diabetics. So in a few months, they have already made their insulin requirement a third. And then at that point, it's easier to try maybe up to 24 hours fasting. And there are so many people who achieve this level of 20% weight loss without ever needing to fast. So plant-based whole food nutrition itself will do it. Calorie restriction itself can do it. This fasting is a meditation. So it helps the mind also empower and make the transformation more sustained. That's why we recommend this Siddha fasting.
Yes, because one of the things is, a lot of, if patients are not working or if they're retired, I feel like maybe it might be easier, but a lot of our younger patients, who are working, to tell them not to eat for so many hours, I don't know if they will buy it. So what are your, the people who have signed up, are they mostly people who are not working and willing to kind of not eat for, are we talking about younger women who are, what's your population like?
Thanks so much, Pooja. I tell my patients that my own colleagues who are in their 30s, interventional cardiologists who work here in our own university and in our VA, Monday morning, they are doing STEMI PCIs, empty stomach. They are hungry and they do it, and they're telling me that it's making them so much more resilient. So if you ask me which is the best day to do a 24-hour fast, I'll say after dinner, 7 p.m. on Sunday, wait until 7 p.m. Monday evening. Water is sufficient, because Monday is the highest stress. Monday morning is the biggest risk for heart attack, and we can drop it dramatically just with the smiling. But if we don't put food in our body, we'll do so much better. So now here in mid-Missouri, we have this culture where so many providers, doctors, nurses, everybody is taking it up. And when patients find that children are taking up plant-based vegan type foods or intermittent fasting, then patients say, my grandchild does this, I'm going to do it. It's possible for people throughout lifetime. And I wish I had started sooner. I started 3 years ago. Until 45 years of my life, until 2018 summer, I did not miss a single meal. Both my parents are physicians. My dad is a cardiologist, mom a pathologist. So we thought 3 meals is needed for us to go on with life. Now I eat only when I'm really, really hungry. That's all it is. And people can learn it and get healthier because of just that simple thing. You don't need food to go to work. You can do open heart surgery and STEMI PCI, empty stomach, and we'll do it even better.
All right. Any other questions, comments?
It's actually harder to be at home because food is so nearby. Your mind is not able to take off from it. When we are working, it's easier to put less food in the system.
And we've seen that effect with the COVID pandemic for people who are working at home.
Our results are all in the pandemic. Our people are losing weight.
Yeah. All right. Any other questions, comments? Thank you so much for really making us think more about this topic, cardiometabolic risk in HFpEF. Don't forget to sign in for your CME, and I will see you next week.
The preceding program is copyrighted by Emory University.